Good afternoon. It's a great pleasure for me to be with you here for my presentation. And I would like to thank the organizing committee for organizing such nice, beautiful event. I have nothing to disclose with respect to this presentation. According to WHO statistics, globally, an estimated 13 million babies are born too early every year. And that's about 25 preterm babies every minute. And that's about 1 million die each year due to preterm birth complication. So by definition, the preterm birth is that birth occurring before the completed 37 weeks of gestation, and it complicates 5 to 18% of births worldwide. What we are worried about is the complication of preterm birth. It's a leading cause of death in children younger than 5 years of age. It has also a lot of morbidities, short-term morbidities, as we all know, including respiratory distress syndrome, bronchopulmonary dysplasia, necrotizing enterocolitis, retinopathy, intravenous hemorrhage, and sepsis. And long-term complication is the babies will be left with cerebral palsy, learning disabilities, hearing and vision problem. In order to prevent a health problem or to reduce the complication, we should reveal more and more risk factors for such a problem. So should we consider the recurrent pregnancy loss as a risk factor for preterm birth? This is the question. For the definition of recurrent pregnancy loss, there is a controversy toward the number of miscarriages required for the diagnosis, the gestational age at miscarriage, consecutive or non-consecutive losses. So, as we all know, the definition of miscarriage is defined as a spontaneous demise of pregnancy before the fetus reaches viability. It complicates 15 to 25% of all pregnancies. 2 to 5% of those miscarriages are recurrent. So, historically, as previously mentioned in previous lectures, recurrent pregnancy loss was defined as 3 or more consecutive pregnancy losses. But the new definition or the recent definition is defined as 2 or more consecutive clinical pregnancy losses. That's up to 20 weeks. So we don't need to wait for the third one to happen in order to implement our investigations and to treat the cause if any detected. A new guideline issued added the non-visualized pregnancy losses have the same impact on the chance of live birth as miscarriage and should therefore be included in the definition of recurrent pregnancy loss. So what is non-visualized pregnancy? We all know to diagnose pregnancy, we should confirm either by ultrasound or histological recognition of a non-viable pregnancy. But for non-visualized pregnancy, it's either a positive pregnancy test, but definitely no ultrasound, doesn't show any evidence of pregnancy, or the ultrasound is not conclusive. So these are the non-visualized pregnancy, and it has been added to the definition of recurrent pregnancy loss. So as we can see here, subclinical pregnancy losses has a diagnostic low status also in patients with recurrent pregnancy loss due to its high frequency in the background population. So most of the pregnancy are lost before the delayed period. So it cannot be recognized unless patients undergo an infertility treatment. So if you see at the pregnancy loss iceberg, most of the patients, as I said, previously, preclinical losses are common, 30% implantation failure, 30% subclinical, and the clinical ones either observed pregnancy loss, that's 10%, or end up with live birth in 30%. So what's the risk factor for the recurrent pregnancy loss? It's maternal age more than 35, paternal age also included, obesity, black ethnicity, number of miscarriage, of previous miscarriages and perinatal death, assisted conception, and smoking, alcohol, and stress. But the strongest association is the maternal age. The impact of recurrent pregnancy loss, of course, is poor obstetric outcome, also depression, anxiety, low quality of life, and also even goes to suicidality, and also financial burden from expensive investigations and follow-up. So what are these obstetric or pregnancy outcomes that's associated with recurrent pregnancy loss? Is the preterm birth, antepartum hemorrhage in form of abruptio placenta or placenta previa or accreta, preeclampsia, gestational diabetes, cesarean section, small for gestational age, and perinatal death. And the most studied one is the preterm birth. So what is whether it's association or causation? Recurrent pregnancy loss and preterm birth are multifactorial in causation, and they have shared etiology, either because of maternal autoantibodies, and the most recognized one is antiphospholipid or antithyroid antibodies, balanced reciprocal translocation, hereditary thrombophilia, genital or acquired uterine abnormalities, uncontrolled diabetes or thyroid problems, chronic endometritis, and polycystic ovary. Also, important to note is that nearly 50% of recurrent pregnancy loss are still classified as unexplained, and 65% of those patients, they have successful live births even without any intervention. So what is the pathophysiology in cases of unrecognized causes of recurrent pregnancy loss? It remains unlikely that there is a causal association between recurrent pregnancy loss and preterm birth, but rather both conditions are reflective of an underlying placental dysfunction. As we all know, it is known that the development and delivery of a term infant requires proper implantation, placentation, and proper growth of the fetus. So a complete failure of such early placentation may result in miscarriage. But if there is but if the failure is partial, pregnancy might remain viable, but with insufficient uterine spiral artery remodeling and a continued imbalance in angiogenic activity during remaining process leading to placental dysfunction disorders. So what is the explanation, or most explained one, is the genetic factor. Genetic association studies found that polymorphism in angiogenesis and vasoconstriction-related vascular endothelial growth factor genes may be correlated with both recurrent pregnancy loss and preterm birth. Also, genetic variation in endometrial control of implantation or maternal adaptation to the pregnancy will have a role. Also important factor I want to stress on is mechanical damage to the cervix and endometrium during surgical evacuation of the uterus for spontaneous or induced abortion. Studies have noticed that a stabilization or even reduced in the risk of preterm birth associated with recurrent pregnancy loss in recent times may be due to decreased mechanical damage from the more widespread use of medical management and cervical priming before surgical evacuation, and this was demonstrated by Oliver William et al. In 2015. And so the association of recurrent pregnancy loss was studied a lot in a systemic review and meta-analysis, and the pooled results shows a 60% increase in the odds of preterm birth among those with previous history of recurrent pregnancy loss. And there appeared to be a dose-response relationship between the increased number of pregnancy loss and increased odds of preterm birth. And the association was stronger with unexplained recurrent pregnancy loss. In other, a cohort, retrospective cohort study demonstrated other problems other than preterm labor, such as preeclampsia, placenta previa, placenta accreta. And also, there are many, many other studies like that. So, what is the clinical significance of such association? Categorizing women with recurrent pregnancy loss as high risk factor for preterm birth will subject such women to more surveillance and consequent intervention, adding more anxiety and significant stress, iatrogenic preterm birth from iatrogenic intervention, because as we all know, we are dealing with a patient who are already anxious about their pregnancy, and this will make their doctor anxious as well. So this will lead to earlier intervention. Also, with advanced antenatal care, if the association is with late preterm birth, the outcome would be good. So we don't need to interfere earlier and make iatrogenic preterm birth. But if a clear association with very or extreme preterm birth was seen, this needs a greater need for intervention to prevent such preterm birth and for women with recurrent pregnancy loss. Management. The high rate of spontaneous isolated losses in general population, the lack of consistent definition of RBL, the relatively good prognosis for live birth among patients with RBL, these all has made the obstetric management of these patients challenging, and few evidence based treatment exists for the management of RBL, making it a frustrating diagnosis for the patient and healthcare providers. So, existing therapies mostly aim to address pre-specified underlying etiology of RBL, like antiphospholipid antibody syndrome and endocrinopathies. However, unless a treatable cause is identified, the overwhelming majority of patients with RBL are managed with supportive treatment, like adding progesterone and aspirin. So in conclusion, women with RBL represents a high-risk obstetric population for placental dysfunction disorders. Enhanced prenatal assessment and intervention may have the potential to prevent or delay the onset of placental dysfunction disorders in women with history of recurrent pregnancy loss, but at the same time, we have to balance against iatrogenic preterm birth. Thank you.